So let me start by asking you, if I could, about this article. What would you see for clinicians who are reading this article, listening to this interview? What would you see as the three main take-home messages you would like clinicians to get and use in their clinical work?
What we're starting to see is that in depression, some of the research we reviewed shows that there's almost as many negative images, that's memories, sensory memories that come to mind when you don't want them to, say of negative past events, that occurs in depression, and it may even be at a similar frequency to post-traumatic stress disorder, but of perhaps more depressive related events. So number one is, like, it's worth us asking people about if they have negative intrusive imagery.
Okay. And it's worth us asking the depressed patient. We're very aware to think about asking the person with PTSD, but you're saying the depressed patient is also having a lot of negative images that it would be worthwhile for the clinician to ask about.
Yeah, and I think that really is worthwhile at assessment asking, because when I think about depression, I often think rumination, which is a very verbal thing. And I ask people about their negative automatic thoughts potentially. But we know that imagery brings quite a different set of processes with it, and a lot of affect. So even if they don't seem as frequent as the verbal thoughts, even having a few of these strong negative images a week might make a real difference to your patient, and really worth finding out about.
Okay, so I'm going to come back to that, but that's number one, is the clinician would do well to assess imagery in the depressed patient. That's one of the main take-home messages.
Yeah, and when I'm talking there, I'm talking about negative imagery, like intrusive or unwanted images, for example, of the past.
Okay. Okay. So two more. Tell me two more take-home messages for the clinician.
So the other one, I'm going to go flip to the opposite. So we've talked about past negatives imagery. Now, another bit that goes perhaps less noticed, or not as noticed as it should do in depression, is the hypothesis that people with depression actually find it quite difficult to visualize positive future images. And if we think about that, this is very important. Like, our ability to navigate towards a goal, to dream about the future, that's actually predicated on our mind's ability to imagine what that future looks like. And this might be a really simple thing, like getting out of bed in the morning, imagining how one's going to, navigate the day, something to look forward to really quite specific hopes and images of the future. So again, a suggestion for assessment, and possibly to weave into the treatment, would be to think about a focus on positive future image-based thinking, and to bring that into part of our wonderful toolkit alongside all the other things we're doing, but to really think about that specifically.
Very interesting. Okay. So to also, in addition to assessing past negative images that the depressed person may be having in excess of, the idea is to assess how able the depressed person is to generate positive images of the future. Beautiful. Okay, I want to come back to both of those. I think they have great, I'm sure you could tell us more about them, but I want to hear the third first.
Clinically, we all know is relevant in the context of depression is to assess for suicidal thinking.
Okay.
And one of the things that we've written about is that suicidal thinking can also take the form of images as well as words. And there's a few studies now that find that suicidal thinking can be associated with what we've called suicidal flash forwards, so perhaps simulations associated with suicidal acts or their aftermath. So I guess this is more a clinical part, again, just strengthening our toolkit, doing all the good things we already do, all the protocols we have to follow, which is very, very important. But an additional form of information might be to ask a patient if they can see in their mind's eye, and if they imagine suicidal acts or their aftermath, because this is also an important source of information.
Wow. as soon as you said that word, what did you say? Like imaginal rehearsal or
Yeah,
word?
imaginal rehearsal. So we coined the term suicidal flash forwards because they can be
Mm-hmm.
so vivid, a bit like flashbacks in PTSD, but
Mm-hmm.
suicidal flash forwards to an event, um, where people might rehearse what a
Wow.
plan might be and what's in it. And I think from an imagery basic mechanisms point of view, that's quite important because we know that imagining can be associated with acting on something more. Um, so that kind of information might be really useful
Oh
to a
my
clinician.
goodness. Yes, indeed. I get a flash of fear when I hear you describe the patient who's actually imagining and rehearsing in his mind and has or her mind a visual image of carrying out an act of suicide or the aftermath, which is another good thing to think about. So that is a beautiful immediate implication for clinicians of something they can assess when they have a depressed patient, a suicidal patient in their office to assess imagery.
I guess we often say to people, do you have any thoughts and plans? But I guess the sort of thing one could say would be if you do have plans, do you ever see in your mind's eye what that plan would look like? Can you tell me what it's like? Do you have, tell me what you see. If I was a film director, what would I see? What would I see in your head? So not to ask leading questions ever, but just simply to get a bit more detail, because if you don't ask about images, sometimes people don't tell you, because when we ask about thoughts, the word thoughts often just means language, like the way you and I are talking now, Jackie.
Mm-hmm.
So it just gives an extra source of information that's really important to weigh in the choice you make with the patient about what to then do.